Welcome to the Healthful Woman Podcast, the fastest growing podcast in women's health. Today's Monday, October 24th, 2022. I'm joined today by Dr. Naomi Feuer to talk about headaches in pregnancy. Naomi is an outstanding neurologist at Cornell and a friend of mine. She's one of my go-to people for neurologic issues during pregnancy, and headaches are the most common. So I'm sure you will find this topic interesting. Hey, for all of you listening on Apple or Spotify, I would really appreciate it if you could rate this podcast, preferably with 5 stars. Thanks for that. Enjoy today's podcast. Thanks for listening. Have a great week.
Welcome to today's episode of Healthful Woman, a podcast designed to explore topics in women's health at all stages of life. I'm your host, Dr. Nathan Fox, an OBGYN and maternal fetal medicine specialist practicing in New York City. At Healthful Woman, I speak with leaders in the field to help you learn more about women's health, pregnancy, and wellness.
Dr. Naomi Feuer, thank you.
How are you?
I'm great. Thank you for joining the podcast. This is awesome. I love it.
I'm so excited to be here.
So we've known each other a while, personally, professionally, and then we were seated at the same table at a wedding. And I'm like, dude, why have you not been on my podcast? And you're like, why have you not invited me? And so here we are. We're together.
Yeah. So we finally made it happen. I'm really, really excited.
This is great. Now, you are a neurologist. You are a assistant clinical professor of neurology at Cornell, just across a few blocks from where I am. How's that going? How are you enjoying neurology in New York City?
You know what? I love practicing neurology. I kind of always viewed neurology as a little bit of a puzzle. I didn't want to be, a jack of all trades. I wanted to hyper focus on one organ system and, try to take all the clues and try to figure out what's going on with the patient. So it's a lot of fun. It's interesting. It's challenging at times, but I enjoy every minute of it.
Yeah. So I grew up in the home of a neurologist. My dad's a neurologist. He's been on the podcast.
That's right. That's right.
And it was always sort of the stereotype, which is probably true, that neurologists, ironically, are very cerebral. Like they like to think about things. Like the problems are complicated,
Yes. We like to think and overthink and analyze. So, it goes well with certain personality types.
At what point in medical school did you realize that you were just, a neurologist waiting to be chiseled out of that block of ice?
It's funny, I think around my 3rd year rotation when I started at neurology, and I was just fascinated by the patient's presentations and the explanations for them. And, linking the pathology that we could see, whether, radiographically or otherwise, with the patient's clinical presentation. I remember a patient came in looking like she had a stroke and it was only a UTI. And I thought, how amazing is that? The things that can affect the brain, from something so severe, you can have the same presentation as something so mild. So, I just was really taken.
Well, now in your current practice, what would you say is your sort of breakdown of patients or sort of things that you're diagnosing and treating? Are you doing more general neurology? Are you more specialized? How do you sort of, maybe as a percentage, how is your day or your week broken down, would you say?
Absolutely. So I'm a generalist in general, and I subspecialize in neuromuscular disorders. I did a fellowship in that at Cornell. So that's sort of my area of expertise, but I treat all sorts of issues, including headaches. I do a lot of spine work, a lot of back pain. I work closely with neurosurgeons. People will come into my office with different clinical presentations or complaints of, they're numb or their head hurts or they feel they've lost some dexterity in their hands and they're not sure why. And it is up to us together to kind of figure it out. And the diagnostic algorithm is always very interesting and, can sometimes, and treatment options also, at certain point, medicine transitions to an art more than a science. And we kind of have to come up with the best formulation to maximize and optimize the patient.
Yeah. And would you say as a general neurologist, are most people finding you just sort of on their own, meaning, hey, I have headaches, I have neurologic symptoms, I have a condition, I'm going to find a neurologist, I'll find someone at a world-class institution like Cornell and they find you? Or are they referred to you by another doctor, let's say, a general practitioner, or internist or surgeon or whoever says, hey, you know what? This problem is sort of beyond my scope. See a neurologist, see this neurologist. How would you say it's broken down? I'm always curious how people find us doctors.
Yes, it's a good question. I'd say for me, majority of my patients come in through referrals from their internists or surgeons, where they have very, very detail-oriented internists. And, when they go for their annual physical, the patient said, if anything happened to me this summer, I had numbness in my arm for an hour, but it went away and I'm better. But, we don't want to leave anything to chance, and we want explanations for what goes on in our bodies. So I will get a lot of referrals from internal medicine doctors, whereas I think the patients themselves wouldn't have otherwise taken the initiative. And then I have patients who self-refer, whether it's Google or their friends or word of mouth, where they just say, I want to get in and I want to see someone because they're worried. The internet also has played a huge role in neurology referrals because unfortunately, I get lots of patients coming in and, they see a little twitch and they're worried about ALS, and we live, with a lot of stress and pressure. And there are a lot of symptoms that can come on that are completely benign, but can be worrisome, especially to let, patients about possible neurological disorders.
Yeah, it's the same problem, you and I had going to medical school. When you learn about all these, diseases, you're like, wait a second, I'm tired. I have leg pain. My back hurts. Oh my God, like I'm dying. And so now everyone has the glory of that because they can find it all on Google and they can, self-diagnose with all these horrible conditions. It used to be limited test doctors, but now everyone has that joy in life of thinking you have something horrible.
Exactly. It's true. I must have diagnosed myself with God knows how many diseases.
Yeah.
None of them actually panned out. But yeah. And then now, unfortunately, I see people tortured. I mean, sometimes part of my plan is no Google. And I'll say, I'm just like, and you got to promise me no Google. It will make your symptoms worse. It can definitely exacerbate things.
Yeah, you have Googleitis and you need to stop. Yeah, get off Google. All right.
It's rampant.
It's rampant and it's spreading. It's contagious. What?
Contagious.
Now, since we're going to talk today about headaches and pregnancy, how often do you have the honor, privilege, and pleasure to see pregnant folks in your practice?
I'd say it's about 20%. I see quite a few.
That's a lot.
Yeah. I think, we worry a lot about pregnant women, right? Because I don't have to tell you, it's more than one life. So it's double the responsibility. And, I think that when it comes to neurological issues, they can be very, very critical and severe sometimes during pregnancy and then very benign. And it's tough to make that call. And it's tough to know what kind of diagnostic workup you want to do and how aggressive you want to be, whether it's in treatment or imaging or, all of that. Because, in general, I like to think in medicine, whether a patient is pregnant or not, or postpartum or not, less is more, except for when you're really, really worried.
And when the pregnant women come to see you, again, is it predominantly people with chronic neurologic conditions who are also pregnant, or are these women who are pregnant who have like a new symptom, again, like a headache or weakness or something like that?
Yeah, typically, that's a good question, maybe. Typically, it's the latter. I'd say the patients who, have seizure disorders or myasthenia gravis or multiple sclerosis, the pre-pregnancy counseling is outstanding. And, we really have good protocols and good data on some things and, guidelines that we follow as to when to stop certain medications, when, what to expect for many of those chronic conditions. But it's when the patients show up with something they've never had before that, everyone can get a little bit uncomfortable.
Right. And I would imagine that headaches is probably, if not the most common, up there with one of the most common things that you're going to be seeing for pregnant women.
Absolutely. Headaches and lots of carpal tunnel syndrome, actually.
Yeah. Oh my God. It's horrible. The poor, I feel so bad. They come in with they look like they're going rollerblading with the wrist splints and it's so much pain. It's horrible.
and painful. Yeah. But it's a great diagnosis to have. I was going to say, if you're walking away from a neurologist with carpal tunnel syndrome, like you know,
Yeah,
you
it's a
won.
win. That's a win.
It's a win. It's a win.
It's a win because it's your it's going to go away after you deliver. So
Exactly.
it's a win. So let's talk about headaches and pregnancy, but just sort of as a background in terms of headaches in general, right? So obviously there's going to be overlap between headaches and pregnancy and headaches in general. How do you think about headaches when someone comes into your office who's not pregnant? Do they come in, they're like, hey, I'm healthy, I'm fine otherwise, but man, I'm having all these headaches. How do you evaluate them and sort of get them from point A to point B with a diagnosis?
When a patient comes in with a new onset head pain that they've never had before, non-pregnant patient. So for me personally, I tend to be very conservative. I always get diagnostic head imaging because, new onset pain, while we presume it's pain syndrome, it's well reported, it's quite prevalent, but, we just want to make sure that we're not being arrogant or missing anything or just saying, of course, you have classical migraines and we're just going to put you on this medicine and you're going to feel all better. I like to make sure that I can define as best as possible what I'm dealing with, and again, women in their 20s and 30s, which happens to be, the time period when lots of women choose to have children, people will, that's the time when the migraines frequently begin in lifetime. So especially for women. So it's important to target it and treat it. And there's this assumption that there's tension type headache and there's migraines. But what we've learned really is that all head pain is really a little bit along a continuum. Pain is mediated by the trigeminal-vascular system. And, whatever is setting off the release of inflammatory mediators, whether it's causing migraine symptoms such as, half the head is pulsating and there's photosensitivity and noise sensitivity and nausea and vomiting and, just complete lethargy, that would be a classical migraine. But then you have people with, if you dial those symptoms down by 50%, and they have a dull ache and a little bit of fatigue and a little bit of something. We could say it's tension, but we're starting to think it's all a variation on the same theme.
That's really interesting. I didn't realize that you are sort of nowadays blurring the lines between these types of headaches. Because, when you read about it and we learn about it, they always say, all right, it's either a migraine or it's a tension or it's a cluster. And, this is this and this is this and this is this. And they're sort of present differently and treated differently. But you're saying actually there's a lot of overlap. It's like a Venn diagram, so to speak, with those.
So there's a lot of overlap. And in terms of treatment, there's a lot of overlap because patients will frequently inquire. They'll say, well, isn't that a migraine medicine? And I'll have to explain to them, that we only have so many tools in our arsenal and they're all targeted, to mediate head pain. And we have to sort of, that goal is to make the patient comfortable and out of pain safely. So we use many of the migraine medications for tension type headaches. We don't really have treatment categories that we prefer. There are recommendations for different types, but at the end of the day, we want to use what's safe and what works.
Yeah. And then when you said you get imaging, what does that typically mean for someone? Again, we're talking about non-pregnant first. Is that usually an MRI, CAT scan? What do you do?
An MRI.
Okay.
And an MRI, of course, is no radiation. It's a magnet. And, patients ask me that all the time. So I generally never get head CTs. I leave that for the emergency room.
And then what would you find on an MRI, or what could you find on an MRI that, let's say, you weren't expecting, but are on the list of things you just want to make sure it isn't? What are we talking about here?
So the primary thing is a brain tumor. When somebody's got a new onset headache, I want to make sure that they have no structural brain lesion. We also want to look for any kind of bleeding aneurysm, or any kind of venous malformations, any entanglement of the arteries and veins. People can have clusters of little veins it's called cavernoma, where they'll bleed out of that and it will cause pain. And sometimes you can also see changes in radiographically, you can see changes when there's pressure intracranially, high or low. And that can also play a role in head pain when there's no structural lesion, but there's pressure changes within the cranium.
And when you're evaluating them before this, you're listening to them, getting their story, asking them questions, doing, an examination, and you do the imaging. Are one of these things usually something that would come as a sort of a surprise, meaning there's nothing about their history and exam that indicated it, or usually already suspicious that it's something different than a quote unquote classic head pain?
Yeah, typically I'll see, there might be a cranial nerve abnormality, such as, one of the eyes aren't moving in the direction that it should. We can sometimes see on eye examinations, papilledema, swelling of the optic nerve. Patients will have, positional components to their headaches. So there can be clues sometimes, as to what the pathology, if there is pathology, could be. But for the most part, that's highly unusual. It's really, because by the time the patient is going, if the patient will have a structural lesion or a bleed that's going to cause a clinical deficit that can be notable, they probably come to medical attention at some point already.
Understood. Meaning, so I guess sort of the takeaway point I would say is if, you're going to a neurologist and you have headaches and they examine you and they say, I think everything's okay. Let's get some imaging to be sure. The overwhelming likelihood is you're going to go and get imaging that's going to either find nothing, which is good, or find something that's not so crazy. And that you're doing it just for those rare cases when there's something that's more concerning.
Exactly. There's times where I'll find things that I wish I'd never looked for, like a Chiari malformation, which is controversial. That's where the cerebellar tonsils are low-lying in the head and can be associated with headaches. And the only fix for that is neurosurgical intervention, and it's not a guaranteed fix. So that's a whole controversial topic. And, you can see certainly benign things that correlate with headache syndromes. But what I'm looking for, and it's always a good, piece of information to have in the patient's chart. But, what we're looking for really are anything that could be progressive and, pathological or dangerous to the patient.
Okay. Now, let's focus now someone, same situation, but she's pregnant, right? She comes to you, new onset headaches, didn't have it before. Is there anything about your evaluation or your maybe differential diagnosis that is different simply because she's pregnant versus non-pregnant? So
with pregnant women in particular, as you all know, early on, there's symptoms of, that it's very common to get headaches, low-grade dull headaches. And those are typically benign and will go away after the first or maybe even second trimester. I could defer to you more on that.
Fine. Keep going, doing great.
But I think that first of all, in a patient, I don't feel reassured when a patient comes in with headaches telling me that they had a history of migraine headaches, because migraine headaches typically will improve during pregnancy. So it doesn't make me think, oh, they're just having more of the same. It definitely raises a flag. The one headache type that is sometimes considered to stay or, worsen or associated with other pathologies is migraine with aura. So migraine with aura can be worse during pregnancy. So whether or not a patient has an aura, which is an event, a neurological event that precedes the headache, such as, colorful lights or, it's typically a visual aura. They see a rainbow of colors or flashing lights or zigzag lines. And those auras are associated with auras, which is followed by a headache, can be associated with worsening during pregnancy.
Okay. So you're seeing someone who's pregnant. Do you still recommend the same imaging typically? Are you less likely to do it or more likely to do it because she's pregnant?
So if the patient has never had imaging before and their headaches are particularly bothersome and, not in line with the classical headaches that might be seen more commonly during pregnancy, my first line would be to probably send them to an ophthalmologist to make sure that there isn't any papilledema or swelling in their optic nerves. But I have a very low threshold for MRI, very, very low. we always worry about things like strokes, which can be caused by hypertension. And again, these things will be seen more in the later trimesters or postpartum period, especially in patients with HELLP syndrome or, other types of, vascular issues during pregnancy. We also worry about, any hemorrhage into the pituitary as it grows during pregnancy. And especially if a patient complains of visual symptoms, the pituitary is right near the optic nerve.
Mm-hmm.
So we really want to make sure that there isn't any, what we call pituitary apoplexy or, hemorrhage into the pituitary because of its growth during pregnancy, because that will cause problems down the line.
Right. And then fortunately, MRI, like you said, since it's not radiation, it's just magnets, it is safe in pregnancy. It might be slightly annoying, but, no different pregnant
Right.
than non-pregnant. It's just your head going in. It's not your whole belly, but it's
Right.
safe. It's safe for her. It's safe for the baby. So it's not a concern from our end medically to have an MRI. So that's,
Which is great.
nice that you can do that. And, I think that, like you said, there are some things that are possibly going to happen in a pregnant woman or more likely to happen than someone who's things like, blood clots or things like, with the pituitary, as you said, or potentially even a stroke, because even though usually strokes are limited to people as they get older, in pregnancy, they can happen for other reasons and, with changes in their blood and, a lot of changes that sometimes there's probably red flags that go up for you, in someone who's, 28 years old because she's pregnant that would really never go up, at that age, with that, who's probably perfectly healthy.
Exactly. And so, really the big warning signs for headache would be, for something really dangerous would be fever, swelling of the optic nerve, or any abnormal neurological findings on exam. Sometimes patients will report something called a thunderclap headache, which is like exactly what it sounds like, a massive loud thunderclap in their head, which could be a sign of a hemorrhage. Sometimes if they say laying down, it's better, or standing, it's worse, that can be a sign of fluid changes that are leaking out of somewhere. So we really want to be careful. We want to be careful with all patients who have these symptoms, and especially pregnant patients with these symptoms.
Yeah, one of the hard things on our end is trying to figure out who to send to a neurologist. Because like you said, a lot of pregnant women have headaches that are just from pregnancy and, their nutrition changes and their sleep changes and their body changes and their stress changes, and very common to get sort of that mild headache. And, it's hard for us to always know who to say, all right, you're perfectly fine, it's okay. Or to say, hey, try, some of this medication, and, and who to say, oh, you need to see a neurologist sort of immediately. So I sort of, we have our ways that we do this, but what would you say, for our listeners maybe who don't see me, let's say, and they're out there and they're having headaches on and off, how should they know if their doctor should be sending them to a neurologist or not for their headaches when they're pregnant? What would you say is sort of a good rule of thumb? Is it everybody, or is it if, they don't respond to Tylenol, or if they have certain symptoms, or what would you prefer as the neurologist?
As a neurologist, I would say that,
everyone.
Right, exactly. Come on in.
Yeah.
We'll check you out. We'll line up the MRI.
Yeah.
We'll do pre-pregnancy MRI.
Yeah.
But I was going to say that I think that, for most people, that those early on dull headaches are okay and don't need neuro referrals. And, I'm a big believer in the patients they know their body, and they know what feels wrong and what feels right. But forgetting the patient report, because that can be highly variable based on so many factors. If they're vomiting, if they're having crazy nausea, which is also a very common finding, early on in pregnancy. But, if they're having tremendous nausea and vomiting with head pain, that's uncharacteristically worse than the typical pain you're going to see. If they're having any blurred vision or vision changes, if there's a postural component to it, whereas when I say postural component, they feel better lying down versus standing up. If they've developed high blood pressure during their pregnancy, I would say those would all be good reasons to see a neurologist.
Yeah, I mean, it's tough. And sort of in practice, it's very common, and we try to reassure women that, it's common, it's probably fine, you'll probably get better. But obviously, not all of them, that's the case. And to try to sort of weed out, who, or triage who should go and who shouldn't. I mean, typically, for me, if it's something that's mild, occasional, and gets better with Tylenol, that tends to be something I'm going to wait on. Obviously, if there's something really unusual, other symptoms, like you said, I'm going to send them to a neurologist immediately. And I think the tougher cases are sort of like what you're saying. Someone is having pretty bad overall symptoms in the first trimester, a lot of nausea, a lot of vomiting, a lot of weakness, and they have a lot of headaches at the same time. It's probably all the same thing. It's probably all related, just a little more severe. And so probably those are the ones who I'll hold off a little bit longer on sending to a neurologist, even though their headaches are a little bit worse than typical. And sometimes it's, you're clued in like, hey, if you have those moments when your nausea is better, maybe you took a medicine and your nausea is a little better for 6 hours or 8 hours, or, are your headaches better at the same time? And if the answer is yes, then probably it's just that. But those, I would say, in my practice, tend to be the toughest sort of situations to figure out, is this really bad headache, something I should send to a neurologist, or it's just sort of a worse case of the typical headache that women get, like nausea is worse.
Absolutely. So it's hard for you guys, especially to gauge, I think especially in somebody who has, I don't think it should be determined based on their headache history. I think that ironically, like I was saying, women with migraines their migraines typically improve during pregnancy. So especially if it's a migrainous type headache, as opposed to that low grade, dull, just my head hurts a little bit, but I can function through this just fine. If it's a more dramatic event or a spell, we could say, then, I would definitely make the referral. But again, I'm sure I put what percentage of women largely going to have headaches, a large percentage, and it's going to be fine.
Yeah. And ultimately sort of the risk is low in sending someone to a neurologist. I mean, sort of, you're going to get a good evaluation, a good history, someone who's an expert in headaches. Maybe they'll order an MRI, maybe they won't, but it's safe. It's not dangerous. Worst case scenario, it's annoying, whatever, because you have to schedule it. Mm-hmm. And ultimately, assuming it just ends up being just the pain of it and trying to figure out the pain and treating it, at least you have an expert on board. Clearly, you're going to be much more adept at treating headaches than I would be. And so if it's something that's not really getting better with really simple measures, even if I know it's not, life-threatening, I'm going to want a neurologist to help anyways, because you're going to be better at it than I am just on the treatment end. So I think it all ends up, in the same place anyways. And, if you get referred to a neurologist because of headaches, A, it does not mean there's a big problem. And B, okay, go, like, great. They're going to be really hopeful, hopefully.
And it's just another set of eyes. It's another evaluation. It's someone else, thinking of different, differential diagnoses of what this could be and how to, help someone safely navigate their pregnancy. I think, it's so individualized also per the patient, how many, what number pregnancy this is and how anxious they are. And, that can play a large role as well. So the evaluation certainly isn't going to hurt them.
Yeah. How do you go about treating headaches during pregnancy? So let's assume you've done, either your evaluation by physical and, history, or you got an MRI and you're confident it's not any of those, sort of bad things. And you're just talking, straight up headaches. What is sort of your progression of treatment for someone in pregnancy?
So most of the headache medications are pretty much not considered safe, which is a problem. Obviously, Tylenol is a no-brainer, no pun intended.
The neurologist must love to say that.
Yeah, it goes with the nerdy type we have. But exactly, it's typically there are certain medications like propranolol is considered safer, magnesium is considered safer, CoQ10 is considered safer. Some of the SNRIs or tricyclics have some moderate safety, but in general, I try, and we can't, Reglan or any of the anti-nausea medications, which are commonly used, Reglan and Zofran, those are considered safe. And Benadryl can sometimes take an edge off as well, also, just because of its sedating qualities. But some of the calcium channel blockers can be used as well. But to be honest with you, I typically try to start with Tylenol and then doing a lot of sort of cognitive behavioral work to modify the pain and to manage the pain, because there's so many question marks among some of our best headache medications, and some of them are absolutely contraindicated.
Do you find caffeine to be helpful?
Caffeine, no, because my patients rebound from it. So if they have one bad headache, yes, go for it. The cup of coffee and the Tylenol will be great. Some of it could be dehydration, hydrate, rest. There's, lots of reasons. But I find that if the patient's having, so that would be for a one-time headache, or if, they just got this really bad headache, or if they got 3 bad headaches. But if they're having daily headaches, I would veer away from caffeine, because it can, cause a secondary headache syndrome of, rebound.
Oh, interesting. Okay. Because I find sometimes pregnant women are, before pregnancy, or having caffeine every day. And then they got pregnant and someone told them not to have caffeine every day. I don't tell them that, but, the Google told them that or something. And then they're like, man, I get headaches all the time. I'm like, well, did you used to be caffeinated and now you're not? They're like, yeah. I was like, well, have your cup of coffee a day and see if that, changes your life. Something's like, yeah, I'm back. I'm better,
And for something like that, I think so, but I would expect the withdrawal from caffeine to go away after a month or so, that they would re-equilibrate.
A month or so. I find out after a day. So
what's going on? Yeah, I would definitely serve a cappuccino after that as well. Or recommend one, prescribe one. But yeah, I think that, after a certain point in time, if you've been without caffeine, I wouldn't want to reintroduce it. But certainly if it's in close proximity to when they were having their daily cup, which, you guys are all okay with as far as I know.
Yeah. I mean, I think that, it's interesting with a lot of the medications, there's definitely hesitation to use them, but there is, I think that we tend to be more, I don't know, I guess liberal in allowing them than you guys are. I mean, triptans, which are used for migraines, all right, if you can avoid in the first trimester, maybe, but it's not like they're known to be harmful. And, sometimes we're okay with those. And people say, I've been getting these, Botox injections in my, scalp and my neck. I'm like, I'm fine with that. And it's, sometimes people aren't. And I think it's one of the reasons it's nice in these situations if the obstetrician and the neurologist know each other, that they can talk, and say, all right, now listen, I think this is the thing that's going to work. What do you think about this? And then we can figure it out and talk to the patient, like, how much risk really is there? And we can sort of decide, as a team, what's going to happen and what we should do.
Yeah. And I agree. The multidisciplinary approach is probably the best one, because, we know headaches, but we don't know, obviously OBGYN like you guys do. And like I said, you guys could determine in terms of, there's a lot of gray in terms of safety.
Yeah.
And we want, but, to have a miserable pregnant patient isn't healthy either. So you really want to sort of collaborate together, because the guidelines are very wishy-washy. They really are. So if I have a patient who's been getting Botox for years and years and years, and that's been controlling their headaches, and then they stopped it for pregnancy, I mean, it's very reasonable that that's why their headaches are back. And, most obstetricians have been okay with it, even though the guidelines are not clear. And some of the patients are just like, I can't live like this. It's funny. I actually had one obstetrician who said, my pregnant women are the most underserved patient population, because everybody is afraid to do anything with them.
Yeah.
And I think that it's important to keep that in mind. I remember I never forgot it, because they deserve treatment,
Yeah, it's totally true. And the fear that a lot of people have to treat pregnant women is understandable, because they're frequently venturing into, sort of a world that they don't have a lot of experience in, and are worried, and the stakes are very high, obviously. And everyone's worried about the baby, and that's all true, and it's legitimate, and it, needs to be understood and cared about. But on the other hand, you also have this pregnant woman here who's suffering from something and needs to be treated, and we have to sort of come together and figure that all out. And I think that with good interdisciplinary or multidisciplinary care, that can be achieved. Because frequently what happens is there's just a lot of people saying, oh, you can't do this. And someone says you can do this. And like, well, what am I supposed to do? One doctor said yes and one doctor said no. And that's very confusing. And all it usually takes is a conversation between the two and they'll sort it out, especially if it's someone who does see pregnant women in their practice. The more, sort of experience, whether it doesn't have to be neurologist, I mean, any other specialist has in seeing pregnant women, the more sort of comfortable they're going to be and the more experience they're going to have with what things are and aren't gray versus black and white. And that's hard. It takes a lot of experience to sort of get through that.
Yes, 100%. And I think that, it's just important to note, I mean, the pregnant patient is a patient. They need to be treated and, they need to be taken care of. And of course, the baby's safety and well-being has to be of paramount importance, but, they don't have to be mutually exclusive. And, there's sort of this old conception I find that, do nothing, just suffer through it. And especially for my patients with headaches, it's not good. It's not good to be in chronic pain. It's not good to be vomiting. I've seen patients with vitamin deficiencies from vomiting from headaches that have caused numbness, tingling, and other things, especially vitamin B1. I've seen deficiencies of thiamine from vomiting, and that can cause, a lot of complications, neuromuscular complications. So we really need to make sure that we have things under control because the patient has to stay healthy in order to continue and have a healthy baby.
I could not have said it better myself. That's perfect. Thank you so much for coming on the podcast and talking about headaches in general and headaches in pregnancy. Again, very, very common, usually benign, and usually treatable, but needs to be evaluated, particularly if they're severe or if they're recurring or if there's other symptoms. But fortunately, again, for most people and certainly for most pregnant women, they should be okay with a proper evaluation and treatment.
Absolutely.
I find folks like you, Naomi. Thank you so much for being there, for being around, and for coming on the podcast to talk about it.
My pleasure. Thank you so much for having me.
Thank you for listening to the Healthful Woman podcast. To learn more about our podcast, please visit our website at www.healthfulwoman.com. That's HEALTHFULWOMAN.com. If you have any questions about this podcast or any other topic you would like us to address, please feel free to email us at hw@healthfulwoman.com. Have a great day. The information discussed in Healthful Woman is intended for educational uses only and does not replace medical care from your physician. Healthful Woman is meant to expand your knowledge of women's health and does not replace ongoing care from your regular physician or gynecologist. We encourage you to speak with your doctor about specific diagnoses and treatment options for an effective treatment plan.